Okay, Travis, you're actually unfortunately in the hot seat all the time. So we start with you. And we're going to walk through this bad boy. Tell me what we're looking at.
It's like the arch.
No, tell me about the study. What is the study we're looking at?
CT chest.
Yep. Okay. CT, contrast, no contrast. Why do we give contrast?
Contrast to see vessels better.
Yeah, you give contrast to your blood vessels. So it's usually non-con CT scan. What is that?
It's like calcium in the aorta.
Calcification in the wall of the aorta by the looks of things. Okay. So what's that?
Ascending aorta.
Ascending aorta. What's that?
Descending thoracic.
What's that?
It's the bronchial.
Yeah, trachea bifurcation. What's this?
Pulmonary trunk.
Pulmonary trunk. Right PA, left PA. So there's a lot of things that you can actually see. Does the patient have an aortic dissection? Can't tell. Can't tell without contrast in it. Okay, so let's go up here. All right, what's that?
Probably the innominate.
Innominate.
Left common carotid.
Left common carotid. Left subclavian. What's that? Innominate vein. Okay, that's the innominate vein. When you open the chest, first thing you got to do is dissect out the innominate vein. It crosses right across the middle. And it's one of the things you can divide or injure accidentally. So you basically dissect this out, sling it, so that you can you can dissect out the rest of the heart and the pericardium. So there's a lot of stuff on here actually, and it's very easy to look at CAT scans and see nothing. What's that? I'm going to give you a little clue here in a minute. What's that? All right, you're off the hook. Next. What? Just describe it. So one of the techniques you should get in, if you're not sure, describe it. Talk yourself into identifying what it is.
Alright, well, it's like similar density to the descending aorta.
Okay, except it's got these black dots in the middle.
Yeah, so is it the base of the apex of the heart?
Nope. Black dots are what? Air. Okay, so watch this. Watch that structure. Kind of goes up there, kind of comes down here, still there, although it's hard to see. Okay, so this is a air-filled structure adjacent to the aorta that runs alongside the aorta and is immediately anterior and to the right of the aorta.
The trachea?
No, the trachea is up here. You saw the trachea up here. So there's trachea. Esophagus. Okay, now this is one of the complications of fixing a descending thoracic aorta is you put a stitch right through the aorta and they get an aortoesophageal fistula. That's why. And see how close this thing actually is to it. Applied anatomy. Everything we do is applied anatomy. All right, we're coming down. Now watch the aorta. Swing towards the midline, okay? Now the reason that this is important is because a lot of the time what happens, let me go back one, is that people mistake diameters of the aorta because they're really looking at angulation of the aorta. So for example, is that's not an aneurysm, that's just the arch. Same thing happens down here as it starts swinging towards the midline. Okay, now let's look at this in a different view. Okay, contrast and no contrast in this one. Okay, this time we got contrast in it, okay? What is, let me see if I can stop this damn thing. What view is this? No contrast in this. What do you call this? Sagittal, okay, all right. So, aorta, what's that?
Celiac trunk.
Celiac trunk, there's that diaphragm thing we were talking about, remember? Pinches right on the top of the diaphragm. What's that? SMA. So, what's that probably? Huh? Renal vein. That's probably the renal vein crossing the midline. Just looking at it in a different view. Let's see what else we can see here that's of relevance to us. The reason patients with aneurysm present with back pain is look at that bad boy. Look at it. You can't even see, you can't distinguish it. And sometimes the big aneurysm will see the front of the vertebra all eroded. So the most common way patients with aneurysm present, if they're going to be symptomatic, is they usually often have back pain more than they have abdominal pain. No. So, okay, what's that? I don't know which iliac it is. One of the iliacs. I don't know which direction I'm going in here. Okay, now watch what happens to the iliac. See how the iliacs swing way posterior. Look, so it's coming down, swinging way back here. That's iliac artery. And so when you look at an AP aortogram, they look straight. They're never straight. They kind of go like this. And if they're small and calcified and rigid, that's a real problem in putting devices up there. Okay, let's go back one because I skipped one. And back one more. Okay. Oh, well, maybe this is it. Okay, and so we're going to keep going forward all the way down. Stomach, and then we're going to go down. You get a quick look at this. Now we're going to go down through these things. So this is all anatomy. Think anatomically when you're looking at these things. Descending thoracic aorta. This is taking over where the other one left off. Comes to midline. Okay. What's that? Air-filled structure in front of the aorta. It's the esophagus. Okay, so again, one of the things is when you're dissecting out the aorta at the cross of the diaphragm, a little bit lower than this, you always want an NG tube in there so you can feel it. You can't feel it otherwise. So you get them to put an NG tube in there, you can feel it. And what you essentially do, like in a trauma situation, is you're a little bit lower than this, but you're going to be pushing the aorta to that side. You don't want to cut the aorta. That's just I'm not cut the aorta. I'd rather cut the aorta than cut the esophagus, I tell you. Okay, what's that? Stomach. Spleen. See the diaphragm? These are, see all this information's on here. Median, right cross of the diaphragm. Median arcuate ligament, left cross. You're going to see that's probably the origin of the celiac starting to come off here. And remember we talked about yesterday, to expose the aorta here, you got to take down the left lobe of the liver. You're coming straight down here to get exposure. So there's a left triangular ligament up above it. You got to take it down. Sometimes these things are really thin and floppy and easy to move. Sometimes they're kind of fat like it is here, and it's difficult to fold it. Typically, you take it and fold it back and hold it back with a retractor. You got to be careful you don't make a hematoma inside the liver, though. Now, come on down. Okay, watch for the celiac. There's the celiac right there. Okay, non-con study, but you can still see it with that calcification at the orifice. So to get to that, you're exposing it right here. You're dividing that diaphragm in order to get control. And if you're going to do supraceliac aortohepatic bypass, aorto SMA bypass, you're going to come off right in the front of this here. All right, what's that? So there's the celiac, a little messy at the origin. That big thing is the SMA, okay? And the next thing you should see immediately below the SMA, right there. Left renal vein. Remember we talked about the collaterals in the renal vein? There's the suprarenal vein right here. This is probably the gonadal vein that is coming down. There's always a posterior branch that drops straight back. So when you do a thoracoabdominal exposure, and we're probably going to try and do these tomorrow. One of the things we learned last time, when you open the abdomen in the first day, oh man, it's pretty rough back there for the next 2 days. So we'll open the abdomen tomorrow. So you do need to wear scrubs when you come over here tomorrow. Otherwise, your seatmate in the airplane not going to like you too much. And so, but typically what you do is when you're doing a thoracoabdominal exposure, you're actually going to take this kidney up. That's the plane you're going to come in. The whole kidney will roll over to the right. And you have to divide this big old communicating branch that goes posteriorly. So partly that is renal artery, but there is a vein which comes back here. So there's left renal, right renal, okay? What's the next branch? Coming down, red cell, flying down the aorta. We're past the renals. Where do you find the IMA?
Between the bifurcation.
So that's probably the IMA there. Do you see it? That's probably inferior mesenteric artery. A lot of the time it's aneurysmal. This is occluded. And there's an aneurysm. Okay, what's that? Maybe you know what that is? Next row. Start at this end. What's that? Watch, I'll give you a clue. Again, I'm going to show you north and south. Right there. Inferior vena cava. Okay, that's the cava. Okay, and that's what it is. Now, when you do translumbar embolization of a type 2 endoleak, we either come in through there, or you can actually go transcaval, believe it or not. You can come in and go straight through the cava into the aneurysm sac. Okay, bifurcation. Okay. What's that? Get up.
Iliac.
Left common. Left common iliac, not iliac. You can't say iliac. We'll shoot you. It's like, what? And just so on the iliac means anywhere from here to here. What's that?
Right common iliac.
Right common. What's that?
Right iliac, common iliac.
Okay. So what's this?
I guess the left iliac vein.
Oh shoot! What did I do? Okay. Yeah. That's what I want to show you is the way this thing is compressed. So look down there, aneurysm. It's got dye in it this time, okay? That's the difference between what I just showed you, non-contrast and contrast scan. Now you actually get to see everything really nicely. What I was going to show you is the fact that the left common iliac vein goes behind the right common iliac artery and gets compressed. And that's called May-Thurner syndrome. You will see that. That's why DVTs are more common in the left leg and varicose veins are more common in the left leg. Okay, so this is the contrast scan, okay, showing the inside of the aneurysm. What's this? Huh? Speak up. Thrombus. Okay, thrombus in the wall of the aneurysm. So when you measure the diameter of an aneurysm, what do you measure? Outer wall to outer wall. Okay, is this an aneurysm of the inferior vena cava we're looking at here? No, this is just the way the slices are cutting down through this. This thing's pretty sensitive this morning. Okay, so let's just walk through these. What are these? What are these things? All right, I got to pick one person. Get up. One each.
Jejunal branches?
Jejunal and ileal branches coming off the superior mesenteric artery, okay? Okay, now you're about to see, what is that thing? Next, keep going. She looks in horror. I was hoping you were getting this one.
I think it's the IMA.
No. Amy, you know what this is? What? SMV. So it's not the superior mesenteric artery. It's too big and too kind of irregular for that. The SMA is much smaller, but it's running in parallel with the SMA. So this is the superior mesenteric vein that you're coming up here. And this is going to come up and join the splenic vein really about that level. What's that? It's amazing how much information is on these scans. You can plan the entire operation of a scan if you look at it and think about it. Amy, you know what that is? Left femoral artery. What's that? Left femoral vein. What's that? That's your sartorius muscle, same thing you were looking at yesterday. So this is the sartorius muscle. So you can plan this entire operation looking at this. Okay, and so there's your approach. Let's say we're going to expose the supraceliac aorta. Okay, just look right here. Liver. We've got to take the liver down. Oh, Lord have mercy. So there's left lobe of the liver. You got to take the left lobe of the liver. See how close it is underneath the heart. This is how you can do. You can get access to the pericardial space. Take down the left lobe of the liver. There's the splenic vein. There's the portal vein. Okay. There's the splenic vein coming in from the left side. We're not going to touch that stuff. There's the retrohepatic cava. Then we're coming up on the aorta. There's the area we're going to be operating on, right there. And if we come anteriorly, you'll see where the diaphragm comes across the front of it. There's the splenic. That's the left renal artery right there. There's the left renal vein crossing the midline. And then we're going to come back up it to the hiatus. And there's the aorta where we're going to expose it. It's right up at the diaphragm. Right there is where you're going to have to get it. And see how close it comes to the spleen. As you come anteriorly, you're going to see all the structures you've got to take down in order to be able to get there. So the whole thing can be planned out. Now let's look at the superior mesenteric. There's the left renal vein. You see it? I'm afraid to let this thing go. It jumps. But look at this. There's the gonadal vein we were talking about. Okay? That's the left renal vein. What's that? SMA. End on the SMA. What's this nasty looking thing? Right femoral. Right common femoral. Calcified vein. So what's that? Pardon? Saphenous. There's the saphenofemoral junction. All kind of laid out there for you. All right. It doesn't really want me to stay on this thing. So, when are you planning to talk? Do you want to go?
It's up to you.
Or are you just hanging for a little bit?
Yeah.
Okay. All right. So, again, It's better if I stand up and point here. Okay. What do I do with that pointer? This thing. I'll get up. Rapid fire. I don't want to make it too easy. Let's go off this. What's that? You can say crappy angiogram. I'll accept
Crappy
that.
angiogram.
Crappy angiogram. What's that?
Left subclavian.
Okay, what view is that?
LAO.
What degree do you think that is?
50 degrees.
Yeah. Okay, we'll give you that. I actually have no idea what it is. Okay. All right, we're kind of going through this. Oh, I'm going backwards. That's the reason. Having some problems this morning. Technical issues. Okay. Better angiogram. Okay. What's that?
That is a vertebral.
That's the vertebral. What's that? Huge thing going up here.
Also vertebral.
That's a vertebral. It's pretty large. Okay. What's that?
That is the internal mammary.
Which one?
On the right side.
Right internal mammary. All right. Ooh. Now this is becoming a little challenging. What's that thing? Other than the fact that the title's up there. Okay, this is what the right subclavian looks like. Right subclavian comes off beyond the left subclavian in this situation, and that's the one that goes behind the esophagus and pinches the esophagus. And it's called dysphagia lasorium. Okay, what's wrong here? Nala, you got it. Maybe. Why does that look so different from this? They're old. Okay, this is what old blood vessels sometimes look like. Sometimes they're just severely hypertensive and they get all kind of loopy like this. And so you got to trace it out. Left subclavian, left carotid. Is it occluded?
Could be.
Why do you say that?
Oh, yeah, I would want to just change the angle and see where it goes.
Yeah, but there are also some clues. It could be occluded, except that if you occlude the common carotid, usually the thing clots back down here. Is one thing. Sometimes it's just a timing artifact with the dye getting there, but if you look at the blood vessels on either side, they're already well filled going up there. So it's pretty unlikely. It could be there's high-grade stenosis up there and things are just kind of filling slowly. So can't exactly say what it is. Okay, what artery is that? Pretty easy when when it's laid out like this. It's a piece of cake for the. You're getting the hard one. Now we're actually making. Now they're diseased. The problem is you're all going to be diseased. The ones you're going to be looking at. So what is that?
Your right common carotid.
Yeah, that's just your right common carotid. So again, the bifurcation is probably here, but you can't really tell when they're loopy like this. Very difficult to lay out the bifurcation to be exactly sure where it is. Internal mammary. Okay. All right, different types of arches. Remember we talked about type 3 arch? So all of the origins of the supraortic trunks are below the apex, of the aorta. So very difficult to catheterize, in something like this. And this is the way that these things are classified. Okay, T for Texas is up here again. All right, so look in. I'm gonna have to make aneurysm. No. What are we gonna do? Changing angle. Cross table lateral. Be normal. If you look at me, it's going to be coming anterior. Ophthalmic artery comes off. It bends back, all in the cavernous sinus, and perforates basically the roof of the sinus, and then divides into these two arteries. What's that? ACA, anterior cerebral. MCA is all what's going to show you in transcranial Doppler. Ultrasound beam fires straight down that axis. So he can tell you what's going on here. He can tell you what's going on here. Sometimes you can tell you what's going on here, except on a Friday afternoon. So the bone windows don't work on a Friday afternoon. All righty. So now we're looking a little differently. Cross table lateral. Okay, this is pattern recognition. Okay, MR. What are these? Anterior cerebral. Two of them. Okay, so you see them superimposed on top of one. What's in here? Corpus callosum. Okay, so it's going back there. What is this? What is that, Zolt?
Fetal origin, BCA, because MC is coming towards you. So because it's a lateral.
Posterior cerebral. Yeah.
Posterior, it goes posteriorly, so it's a fetal origin BCA coming up from the carotid. Because when you look at the anterior, so all the other branches will be MCA.
What's that?
So MCA would be all these. When it's coming this way, and this is the, you can imagine that this is what the bounds would be.
Vascular. Okay? This stuff's hard. You're not going to need all this stuff. Okay, so different ways basically of looking at this. This is a 3D reconstruction we can do in the operating room. So these new hybrid rooms are CAT scanners. That room back there, you probably should have a look at it. If you didn't see it yesterday, is the CAT scan in the operating room. We can create all of these things, and it allows us, it's the world you're going to live in, it will transform how we do this stuff. You don't need to send a patient to radiology. We do our own CAT scan. We fuse it. We can use it to fuse image. We can use it to guide. Okay, what's this? Do you know what we're looking at? This is kind of the jaw all kind of pulled out of there. These are the ribs. Vertebral. Okay? Internal mammary artery. You just kind of segment out the areas that we're going to be interested in. All right, now, let me see if that actually flows.
Can I switch you up?
Yeah. Next. Because one of the things, I guess now, one of the things you'll learn is that watching flow patterns and filling patterns, we're just showing you static images. There's so much more information. Okay, so, Amy, you know what this is?
Yeah.
Right. Well, no, we're actually in, yeah, so that's the vertebral. Okay, stenosis at the origin we're looking at. Inferior mesenteric artery. How do we get there?
Internal mammary?
Internal mammary artery, yeah.
How did we get
Did I say inferior mesenteric? Internal mammary, sorry. Yeah, okay. How do we get there? How do we do this?
Angulation? Maybe from
Yeah, okay. Puncture the groin. So this is a sheath that's up here, okay? And you're going to start seeing these devices over the course of the next couple of days. So this is a sheath. It's got a spiral. What you're looking at is the reinforcement that's in to stop the sheath from kinking. And then what you look at is radiopaque markers. This is how you see these things. Normally they're not radiopaque. This one's a little different. You'll see a radiopaque marker band in the end. The catheter always projects a little bit beyond that, and we're going to basically be injecting through this. This is not them. This is us. You got all these diagnostic tools, you know, in your hand. And so this is an example of catheters come up through the groin, it's into the vertebral artery, and we start injecting in the vertebral artery. Maybe you ever done an angiogram? Anybody been involved in doing an angiogram? Okay. All righty. And so this is us doing an angiogram. I think we've killed the head to death. Let's just go on through this to other stuff. Zolt loves this stuff, but
I'm not going to talk about TCD.
you are?
No, I'm not.
Okay.
Can you go back to that one?
Yeah.
Because I think that's one very good lesson.
Which one?
One more. This is beautiful.
Okay.
No,
We'll go
next
forward.
one.
I'm coming. Yeah.
So, right upper corner. What is your diagnosis based on this? So, what are you injecting? It's an AP view. Injection.
I won't tell them. If you don't tell them, you can look really good.
Yeah, very good. So, and this is what you see when the cross
Grab Zolt seat. Yeah.
all the way. And this is again injection coming in. You see MC, AC coming across, and you see the other.
I showed him it yesterday.
Oh,
They have to get it. I lied. I'm going to tell them. Yeah. Okay, so let's go on through this stuff. Don't trust anybody in this business. You must have put this presentation together, so. Okay. Okay, so, well, this one's a little more complicated, but, okay, so let's talk through this. Catheter and the aortic arch. Aortic arch injection, okay? What do you call this? Bovine origin. Arrow's a clue. An occluded left subclavian. This is the same patient, okay? With more clues. Arrows are usually clues, but sometimes they're misdirection, so you never really know. Yeah, so injection, catheters in the aorta, 20 for 20 injection. What does that mean? 20 for 20 injection. Huh? All right, you're up. What does it mean? And do you have any idea?
20 milliliters per second for 20 seconds.
Yes. So powers for 1 second. That's when you set the power injector. Okay. Not them. This is us now. This is all in our armamentarium. What pressure are you going to inject it into? How are you going to inject it at? About 900 psi. Okay, on the arterial side in the aorta, you're up about 900 psi. And this thing is called a pigtail catheter. Okay, looks like a pigtail. It's also a flush catheter. Okay, so there's two different types of catheters: a diagnostic, straight tube with a little hole in the end, and a flush catheter. This has got multiple holes all around here and down the shaft. If I injected with a diagnostic and end hole catheter in the aorta, it will go zip, down one side and you won't see the aorta. You need something that blasts the contrast, whether you're in the inferior vena cava or in your aorta. See how this is nicely opacified? That's because this thing is spraying contrast across the entire circumference or the cross-sectional area of the aorta. Okay, so I'm just thinking away from there are flush catheters for opacifying big blood vessels with high flow, and there are diagnostic catheters. And so what you saw earlier, you know, when we put that thing up in the vertebral, that's a diagnostic catheter. That's an end hole catheter. You inject in the vertebral, you don't do 20 for 20 at 900. You'll back it down and you'll do something like 5 for 10 at 500. These are things you basically that you'll just learn. And typically when you're trying to pacify the other side of an occlusion through collaterals, you'll hear the phrase film long. You go on the injector, you hold the fluoro, and you stay, because initially you're not going to see anything here. This is going to take a second or two, and you'll see this flow in retrograde coming down, and we'll start filling the arm. You never get quite as good pictures as you're going to get by direct injection, but that's all you need to know. Okay, so patient's got arm symptoms. What are we going to do? Pardon? All right, you can bypass them. So do what? From where to where? So you got all the information. You're going to bypass from here. You're going to bypass to there. Okay. You don't want to do endovascular 1, endovascular 2, and endovascular 3. You could. You're probably better off. It's a little shaky going through a long occlusion here, okay, because this thing's full of thrombus. So we'd probably bypass them. And if it was a stenosis, we'd put a stent in them. But these occlusions are a little more hazardous to actually take on, okay? This is kind of what looks like light. All right, I don't want to do that. So, okay, these are all carotid arteries. Kinked. 180-degree bend. Fix it. Leave it alone. Okay. You will. One of the things you'll sometimes, the way this is going to present to you, I got a carotid aneurysm, big old pulsating thing in the side of the neck, and it's very difficult ultrasound actually. So, how would you sort this thing out? Kink carotid's referred, and they say you've got an aneurysm.
So we would probably do a 3D, and on the GE you can do almost like a
Mm-hmm.
and you would just track the entire, but you can get probably the same.
So you got to take the probe up and over and around, but it can be hard.
And most likely you're going to have increased velocity in return. So I think that's one of the things that you're not going to pull the stenosis when you see the king and your velocity is 150, for example. And we see that kinking, as you said, in older people.
Yeah.
So it's very interesting how this kinking happens more.
All right, another one. Common carotid injection. So end hole catheter in the carotid, injected. All right, this is a test. Describe what you, look at that picture and tell me what you see. I've already given you half the story. Okay, so there's, you see a bend. This thing doesn't project on that. No. Okay, you see a bend. What else do you see? Pardon? So again, I want you, every time you look at these things, go through this exercises. Tell me what you see. You haven't even told me the obvious stuff yet. Oh, is that you? Do you have this stuff in your neck? Pardon? All right, so there's a bunch of artifacts up here, or it could be staples, which tells you the patient's been operated on, you know. So all bets are off. What is that, you think? Pardon? This looks like, what vessel is it? Or what region of the body are we in? Pardon? Neck. We're in the neck. Okay, this is, you can see the silhouette. What kind of study is this? What's different between these two things? They're both angiograms. Yeah, no, this is just so this is called digital subtraction angiogram, okay? It pulls out all the soft tissue and bony landmarks, leaves them in silhouette in the background. There's his jaw, okay? There's his jaw. So, again, easy when there's a nice little, if I'd drawn in a little branch here, with branches that went to the face, you'd be knowing this in a heartbeat. Problem is, you're going to see stuff like this, but it's not normal. So this is an occluded external carotid artery. And it's probably happened because the patient's being operated on. This is an internal carotid artery. It just doesn't have an ECA coming off it. But, you know, again, describe these things. You know, what region of the neck are we in? A bunch of clips. The patient's probably had an operation. It's not normal. I can't really tell exactly which vessel that is. I mean, could it be a vertebral? Doesn't really look like a vertebral, but at least we're in the right ballpark. So describe what you see. All right. Too much. Could you want to go through this thing? He's just desperate to.
Can you go back just one? Sorry.
Yeah.
So the only one thing is important on one more. So neuroradiology renaming the number of the carotid. So previously we studied with C1 and we're going down. We know they are starting around, but again, C4-5 will be still your sign point. So this is just be aware that there's an old and a new version. Next. This is your kinking in the ICA. So actually this was a really young person. We just wanted to show that this is again a 3D reconstruction of the CTA. This is not your angio. So CTA gives you that, and also when you see Vitrea or something, give you a hint that this is using an extra software from your CT to make a reconstruction and make it spin like that. The same thing can be done on the angio. This is what we call dual volume. I think you just showed that a few slides before.
All right. Okay, no. This is a CT angiogram, okay? Gives a pretty good picture of what's going on. All righty, so how would we use this? Patient in the office, they may have come in with bilateral buttock claudication. They got a stenosis in the distal end of the aorta, okay? That's something that we'd be able to treat. Now, you can't tell absolutely there's a stenosis in this until you get different views, but again, sing it out. Well, I'm going to walk you down. What's that? No, give me which part of the aorta. Pardon? No, ascending? No. Descending. Okay, but where? We're in the abdomen here. Typically, you refer to the descending as in the chest, okay? We're in the abdomen. So we would say this is suprarenal aorta, okay? That's actually, what aorta is that? Splenic. Left is probably down a little bit lower. That looks like it's going to the spleen up here. Again, it's not easy to tell basically on one view. These things are all superimposed. So that's probably SMA coming down here, laying on top of the right renal artery. Maybe that's the SMA here, actually. What about that? Right at the middle of this thing, right about. Describe that to me. What would you say? Just take it at face value and describe what you see. Heavy calcification. Yeah, above the bifurcation. Looks like it's normal or abnormal? Looks like it's got a stenosis in it. So if the patient had bilateral buttock claudication and walking 100 yards, can you account for it based upon that lesion? Yeah. So you're always going to be taking the history, thinking what the vascular anatomy is when I'm seeing you in the office. It's very gratifying when you get the CT scan and the whole thing actually fits together. Doesn't always happen, unfortunately. Okay, so internal iliacs, what's that? Profunda, right profunda. These are the perforating branches coming off the profunda. We take that out, branches are going to come down through the muscle and recollateralize down to here. Okay, what's this? What's that? That little thing? Tibioperoneal TP trunk. Okay, what's the one in the middle? Huh? Okay, so when you go through the groin with a Fogarty catheter to pull clot out of there, which artery does it go down? Huh? Pass it all the way down to the ankle. Comes all the way down to the ankle. Which artery is it in? Why? Straight shot goes down the peroneal. Okay? Can't really get it in, unless you do wires and things. You can't get it in the AT. Usually doesn't go into PT. Almost always goes straight down the peroneal because it's the continuity of the tibioperoneal trunk. Again, it's all thinking anatomically. You can figure out where these things are going to go. And so when you're going to, if there's an occlusion here, we typically make an incision in that baloney pop, come down to this. You want to open the artery right here, and you want to dissect down here, dissect out both of these so you can direct a catheter down into all of these different blood vessels. All right, okay. What angle is this on the image intensifier? Oh, now we're getting tricky, huh? Who's up? I don't know where we stopped. Honesty is a good policy. Go ahead, you're up. You look guilty, so you get the question. AP? No. It's this is AP, okay? And when it's AP, see where the origin is? So this is the image. If this is the image intensifier, the way you're going to look at the left internal iliac artery, you need to go RAO. Okay, that's the way you open. If you want to see the origin of this, you go LAO. You go to the opposite side, and so they lie on. If this is the internal iliac, bifurcation is a little higher than you think. You rotate it, rotate the image intensifier, and you can see into it. Okay. Branches. Well, you got most of these already, I think. Okay. What's wrong with this? What's the most common place you get occlusion in the superficial femoral artery? You're up. Yeah, well, not as the enters the Hunter's canal, at the adductor canal, right above the where you were exposing it yesterday, where you see it, it gets caught in that tendon, and that's typically where it gets occluded. But you can lose the entire SFA. You can see people who the entire SFA is out, and they may be completely asymptomatic, actually. And so again, here's these collaterals, these muscular collaterals coming down that will reconstitute this distally. If there's no symptoms, you don't need to do anything about it. Okay, and this is one of the big things that drives us crazy is people intervene in these all the time, and they don't need an intervention. Okay, now it's getting a little harder. All righty. So, watch my finger. What's that? Pop above knee popliteal. Okay, what's this? The knee joint. Everything's going to be described in relation to the knee joint. Well, this one's a little trickier. What's that? No, we're above the knee. A lot of collaterals. It's not one of the vessels that you would know. These are geniculate collaterals, okay? But it looks like it's the continuation of the popliteal. Popliteal probably occludes right here. This is probably coming anterior or posterior. Oh no, what about this thing?
That's still popping.
Yeah, that's pretty hard to know. It probably is still pop. There's none of the typical branching patterns. It just may be the angle, actually. That may be the AT. See how confusing it can become because they're all superimposed on top of one another. So one of the things you really have to work to when you're trying to figure out how you're going to bypass these patients is make sure you understand, which vessels. And sometimes you get multiple different angles in order to be able to be sure. It can be very difficult when they're all superimposed in the middle of the calf. It becomes a little bit easier when they start coming down here. Okay, so fibula, lateral, medial. What's that? Why do you say that? Yeah, it's coming anterior. It's usually kind of midway between the two malleoli. That's the dorsalis pedis artery that you're looking at down here. It's a continuation of the anterior tibial. Now, this is lateral, this is medial. Posterior tibial usually comes down, but obviously behind the medial malleolus, and then it divides. You can't see it here into the planar arch, there's a planar arch and planar branches basically down inside the foot. It's easy when it's all laid out like this for you. So you can get the same anatomy, in this case basically it's off an MR. Okay, nice we have labels. I think we've done all of that stuff. So once again, we said yesterday, subclavian artery begins and ends.
The subclavian begins at the top of the carotid
Mhm.
and ends at the distal edge of the first rib.
Very good. Okay. And then we talked about the axillary artery, begins and ends.
First rib, ends at teres major.
It is major. Very good. All righty. And we'll show you some of these exposures. What is there? Pec minor. Okay. So these are all these different branches that we've talked about. Again, the branching pattern on the arm is very similar to what it is down in the leg. So there's a profunda brachii, it's the profunda branch. These circumflex branches go around the neck of the humerus, and that's, you know, the axillary nerve is there. That's how you get in neck fractures. That's how you get an axillary nerve palsy, and it can disrupt a whole bunch of these. But there's huge collateral supply, you know, actually up here. Most of these are going to be irrelevant to you. I think we talked about most of the stuff yesterday. So again, you know, the patients that we deal with are, firstly, he's got hyperemia in his thumb, maybe he's got an abscess or something like that here. The patients always have disease, particularly the ones who you're going to be operating on for end-stage renal disease. And so here you can see radial artery comes down. The princeps pollicis artery is the main artery that goes up to the thumb. You can Doppler that and you can hear that. Ulnar artery here basically is occluded, and these are incomplete arches that you're going to be looking at down here. Visceral circulation, we've already looked at this. Okay, so here's a catheter has been placed in the origin of the celiac artery. Okay, so next up, what's that? Usually it's a lot more. One of the ways you recognize the splenic artery is it kind of goes up and down like this. You don't really see that very well in this particular situation. What is that? Common hepatic. When does it change to the hepatic?
When the
Gastroduodenal, very good. And then you got the true hepatic, and it divides into what? Right and left hepatics. We'll give you that one. Okay? This is kind of what it looks like in an MR. So what artery is that? Just starting to recognize patterns. Okay, SMA, the SMA pattern. What are all these things in the background? And what is that thing? We already looked at it on one of the other. It's an SMV. Okay, a lot of information on there. SMV branches. Okay, inferior mesenteric artery. So, patient comes along with belly pain. You think they've got mesenteric ischemia. What vessels are you going to look at? Celiac, SMA, IMA, and hypogastrics. Okay, those are the four things that you're going to be interested in. You really kind of want to define. So, again, kind of catheter is this? You're up. Pigtail catheter. Injection rate?
20.
Very good. Okay, blast across the entire thing, and so it's up high. So this is positioned at the hiatus, so it's filling all the vessels that are down in there. Okay, what's that? Splenic. Common hepatic. What's this? That's the GDA. Duodenal ulcer. Sitting on top of this, roads into the GDA. You may get called. Come up here, you put a couple of coils in here to kind of block this off. Sometimes you got to come from the SMA in order to be able to get it to, inside the hepatic artery. What's that? Left renal. Please. Huh? Can't hear. Oh. Jejunal branches, okay. So again, hard to tell because you can't see the SMA. Why can't you see the SMA? Because you're looking straight on top of it. So the SMA is going to be coming out here. You just can't see it. It drops along the front of the artery. You still can't see it. Angles off to the side just a little bit. These are all branches coming off the SMA. And so Dr. Bashar is saying you do this angiogram to see if the patient's got an SMA stenosis. What are you going to do next? Huh? Loud and proud, as Dr. Feedman would say. Cross-table laterals, only way you can see the origin of the celiac and the SMA. Then you're going to have the patient's hands are going to be in the way. One thing you do with the arms up, it's kind of a pain trying to go cross-table lateral in order to be able to get all this information. Okay, so what am I looking at here? Okay. What kind of catheter is that? Okay, so let me walk you through this. I'm entirely sure how this was shot because the whole thing's a pacified. It looks like you have two catheters here, okay? One on top of the other. One's white, one's black. Why is that?
Yes, sir.
Yeah, what's been done is you probably got what's called an image or hold on top. You take the last image, overlay it, and then you put a live image on top of it. So this is, one's a virtual catheter. It was there, you know, before we started manipulating it, and see, and this is probably the real catheter because it's engaged in the origin of SMA. And so this is a reverse curve catheter. Okay? So sometimes if you have a downward projecting target vessel, and you come up with a catheter shaped like this, it'll go, try to put a wire up there, and just backs the whole thing right up. So what's been done here is you've got to reshape this catheter. The problem is that the diameter of that is too big for it to reform inside this artery. It goes in straight over a wire, you pull the wire back, and it goes like this. And you really want to go like that. And so you got to push it up in an area where there's enough room, or you engage the tip in an orifice, and then you push up, and you pull the wire back, because this one is engaged, pulling the catheter down. Okay, and so the idea is it come down like that and pop right into it. So these are useful catheters, but they're also can be a bit of a pain to try and reform them. And so this is downward project. It's like shepherd's crook catheters, Sims catheter, a variety of different things that you can get from that. And that's usually how you show an SMA. So here's the SMA origin. You can't tell. Here's the hepatic. I think you got everything on there that we already talked about. What is that? I better read it myself. I'm not entirely sure. Is that a celiac or an SMA? Hard to tell. But there's disease at the origin of this thing. What are these? What's this? That's the renal artery. Okay. And again, it's why it can be very confusing by just presenting you the same data, you know, in a different direction. You're looking cross-table lateral, and you've got these renal arteries, which you're used to seeing coming straight out the side of the aorta, are coming straight at you, or running away from you. What does it say it was? Not normal. Okay, we'll move on from that. Sometimes you see chunks. This is a cerebral mesenteric artery with a chunk missing. This is an embolus that's basically going down that. Stenosis, IMA, tiny little IMA. So we worry about putting stents and things in there. You may lose the IMA. Probably doesn't make any difference when the IMA is this diminutive, but it certainly can happen. Are you speaking, Carlos? You're just hanging.
I'm going to have the case actually.
Okay, no problem.
For the case.
All right. Wait, why don't you talk them through some of this then?
Yeah, sure. Well, I think the previous slide that you missed was so usually for those mesenteric ischemia, right? It teaches that you need two vessels, right? 2 out of 3. I don't know if you already talked about it.
No, go ahead.
Yeah, so you usually need 2 out of 3
you want
to be
him
diseased.
mic? Here, hold on.
In most patients, you know, most patients that if they're coming from the OR. Thanks, of course. So that's why when you see a patient with chronic mesenteric ischemia, I mean, acute is completely different problem. But you have chronic mesenteric ischemia, you usually need 2 out of 3 to be diseased, right? So, but you could have individual ones, and these are actually the hard ones that you might get see in clinic. You're like, well, could be one of them could be single vessel disease, and they have problems. So, out of the 3, which one do you think, if it is just isolated, this vessel might cause some problem? SMA, that's very good. So, SMA, sometimes you can have an isolated SMA occlusion. Patient could have problem. It happens probably, like I think I remember was 9% of the cases it could happen, followed by celiac, which has less, but celiac also could do it. So usually we went away from just ballooning those chronic mesenteric ischemia, because usually ballooning isolated just angioplasty fails. So now we move to stenting them. But if you have this case and you're 100% sure, actually you might balloon it and see what happens, right? You balloon it, if things look okay, it opens, there's no dissection, just leave it alone, and then the patient responds, and be like, okay, well, one, you got your answer, and then if there's no symptoms come back, now you can go ahead and stent them next time you intervene on them. So that's it. I mean, we talked, so you think this is an accessory, or this patient has 2 renals on the right? It's probably 2 renals, right? The patient has probably 2 renals on the right one. What about this one? Do you think this is IMA or lumbar, or? So it's going into the renal. So this is probably an accessory renal at the bottom. So So usually for aneurysm surgery, I mean, most people, if you ask them, they say anything less than 3 millimeters accessory, you have no problem covering or sacrificing. Anything more than that, you want to think about it, see if you can salvage it. Is there any test you can do to see how much that's contributing before you shut down the vessel? It's a nuclear test, nuclear medicine test. Split function, renal split function. It's a nuclear medicine test. It tells you this kidney is contributing 45%, this is 55%. And actually, sometimes they might even tell you how much each branch is kind of perfusing the kidney, and kind of gives you like more like a scientific, add some science to it before you do something to embolize the vessel. What is that? Okay, what's the problem with the horseshoe kidney? Like from a surgical standpoint, if you want to operate, let's say a patient has an aneurysm of the horseshoe kidney. What's the challenge?
You cannot do a trans-abdominal approach open.
You can, but so
could you do a retroperitoneal?
So you can do retroperitoneal, but so trans-abdominal, some people do it. Trust me, it's been published. People talked about that. So you can do whatever you want, but you have to be careful. Yeah, I mean, you don't want to cut it in the middle, because if you cut it in the middle, right, I mean, you're going to lose some of the kidney function. Now, having said that, don't say that, Dr. Bashara told me this. If you go back to your program, sometimes when kidney is fused with like isthmus in the middle, you might get away with cutting it. But again, for the boards or whatever, don't tell them I said that. So for you, so usually you want to avoid messing with it. But you can do trans-abdominal, but just be careful. But you're right. If you go retroperitoneal, because if you go retroperitoneal, you lift everything up, right? So you're looking at it this way instead of looking at the aorta like this way. So retroperitoneal, but still, what's the challenge with horseshoe kidney operatively? Besides exposure? Well, not really. I mean, you guys are going to be awesome surgeons, so you can mobilize anything. Blood supply. What's the blood supply to the horseshoe kidney?
It's off the iliacs.
Could be off the iliacs. Any iliac? All iliacs? Common, internal, but yeah. What else? Off the bifurcation, distal aorta. Yeah, so it's variable. So that's why you want to make sure you have a good study, see where those are coming off. Can you treat it endo? Can you treat it open? Where can you clamp? Is the aneurysm in it? So it's a challenge. So what over here? What do you guys think? Absent right kidney or to which kidney? To the right. You're right. I mean, it's filling. You can see it. I think that's a shadow for the right kidney. But you're right. It looks like it's out, and there's a high grade on the left, right? So usually atherosclerotic disease, the word spillover disease, like one of my favorite questions I ask our residents. So what that means is that usually it's actually disease that starts in the aorta and then spills into those vessels. So that's when you stent them, you want to put the stents 3 millimeters outside, protruding a little bit into the aorta, so that you can actually treat also that spillover disease, from the atherosclerotic aorta. Same thing for the origins of the common carotid, left subclavian. Anything that comes off the aortic, you want to always kind of push your stents 3 millimeters in, so you can cover that spillover disease. So, and then usually if you're going to stent them, which is a better stent? I think tomorrow we'll talk about endo more than open. Balloon expandable, why is that?
It's easier to place it where you want it, like precisely.
So it's a precise deployment, okay? Precise deployment, all right, okay, what else? More radial force, that's very good. So for this type of problem, right? You don't want to put a balloon expandable in the SFA, right? Because you're running and you're going to move, you might pressure, right? So that's you put self-expand in the SFA. Same thing for the carotids, right? I mean, the reason we don't do balloon expandable in the carotids is that if you have a fight with your spouse or something like that and she chokes you, you might shut down the the stent. So, but if you're self-expanding, hopefully it will re-expand again and it won't be an issue. So, But yeah, so this is and again, one thing for kidney, what do you think is? Have you guys heard of any of those recent studies, Astral and Coral?
It doesn't do much.
Yeah, so I mean, so it's a challenge. I mean, when I was in training, we actually were doing a lot for us. When I first started, I was doing quite a bit of renal artery stenting. No, only time I probably do it when I'm doing fenestrated cases, but usually they're normal. But yeah, I mean, because of those data, so medical management obviously is as good as intervening on this patient. But there's more to it, size of the kidney. So what's a normal size kidney? 5 centimeters? Oh my God! I hope not. Maybe in a patient on dialysis. A little bit higher. Usually it's like 12 to 15. So why is that important? Any studies on size of kidney and intervention? Should we just intervene on any kidney? Let's say this is your kidney and this 6 centimeters. Well, not that it's alive, but you're probably not going to help it much, right? I mean, it's almost dead. But you might kill it more by showering some of that stuff when you're stenting it. Yeah, usually the cutoff is 7 to 8 centimeters. So people say, well, I don't know if you should go after that kidney, But sometimes if you have acute decline, sometimes you have patient coming with acute decline of kidney function or size, and these are the ones you're like, whoa, maybe I should do something with them to intervene, right, to help them. So it's still out there. So this is one area that renal vascular hypertension still have. Well, I wish they don't have this on. So so this is what we call fibromuscular. This is typical appearance of a fibromuscular dysplasia, which we call string of beads. Usually in young females, same thing for carotids. Okay, so this is the same thing you can see in the carotids. And usually for those, you balloon them. Usually there's some webs on the inside, and you balloon them. So this is actually one area where you can help the patient if they have hypertension, and you treat it, and you could eventually help them. Same thing for FMD of the carotids. They come with TIAs or something, then you can actually help them. And you probably want to do it over a filter because there's really some thick webs that when you balloon that might get dislodged and cause some problems. So we talk about FMD carotids and the renal. What else could you see it? Third common location. Iliac artery. Yeah, usually they say it's like in a straight long segment. So typically your right is longer than your left, right? Because of the anatomy. So that's why the right FMD renal is more common than left FMD. Renal artery aneurysms, those could be a challenge. That's a common location out there in the hilum. So what does the word aneurysmorphy mean? Do you guys know what aneurysmorphy means? Aneurysmorphy.
I'm right here, Charles.
Okay. Yeah, they haven't. Who was the first person to talk about aneurysmorphy? Some history. His pictures on the Southern Vascular, which, by the way, you guys should all be members of your regional societies wherever you're going. So make sure you do that. So no, you repair it. It's repair. Roughly repair, right? So basically you cut the edges and you repair it. But usually for those cases, what we usually do is just cut the edges and get a piece of vein and just like run a patch. But it was Dr. Maras, Rudolf Maras, chairman of surgery at Tulane. He talked about aneurysmorphy. So the first case he did was aneurysmorphy of the brachial artery. And actually, funny enough, when he fixed it, the patient came back and recurred. And that's because there was some branch coming into the aneurysm. And then he opened up the aneurysm again and sewed it from the inside. So technically, he was the first one to describe type 2 endoleak, right? But he didn't think about it type 2 endoleak at that point, right? Because we were not doing stenting, but it was a type 2 endoleak. That's what it was. So he should be the first one credited for type 2 endoleak. But he didn't call it that. Yeah, so usually they usually occur at the branch points. Venous system. Pain in the butt. I had one of my fellows call me saying the patient has DVT from here all the way above the renals. What should I do? That's a problem. I don't know. It's license. Do something. But it was an interesting picture actually because so the clot actually goes above the renal veins, and actually, but the veins are spared. And so why is that?
Lateral.
Hmm?
Lateral.
No. There's no collaterals. I mean, just the renal veins. The renal veins are actually open, but there's actually it's an interesting picture. So clot, and kind of open, and clot again above and below. So typically, even in arterial system. So that's one thing I always kind of I hate it when people call me the residents say there's a focal carotid occlusion. You never ever. I mean, I should never say never ever, but typically you never occlude a focal occlusion, right? When you're gonna occlude, you're gonna occlude to the first branch. Right? When you have aortic occlusion, we occlude to the renals, right? So renals actually what keeps the aorta from occluding, progressing further out. So when you occlude, usually occlude the ophthalmic. Yes, that's good. Yes. So never. I mean, so if someone tells you, if the report tells you, I mean, that's what I use. I call as well, like, Chief, focal occlusion. I don't believe it. What do you think? He's like, no, you're right. There might be some flow. So never stop. Never assume it's a focal occlusion, the carotid, and walk away. More investigation. CT, angio, you have to do something. So we never ever, unless maybe iatrogenic or something, we actually have focal occlusions. Okay. So and that's why, because there's flow in the kidneys, so the kidneys actually, because of the flow, kept the clot from. But obviously, you know, the patient's not anticoagulated or something, it might actually eventually progress to complete occlusion of the renal. But that's because there's flow. So that flow actually prevents that clot from coming into the, you know, those branches. They might have spillover, like, you know, for these aortic occlusions. If you guys see one when you have aortic occlusions, you have the clot actually kind of spilling over into the renal artery. Sometimes you have to do endotrectomies when you do an aortic bypass for these cases. So, you know, yesterday we talked about that we're going away from calling the superficial system. I think we talked about the anomalous vein, right and left SVC. Right, we talked about, I guess yesterday we talked about the conodal veins, right? Right side it drains into the cava, left side drains into what? So I don't know if you guys remember, you know, that was like one of the favorites, USMLE questions. They tell you a patient comes in with the left-sided varicocele, and the diagnosis is, well, I'm not saying young guy, let's say someone in his 50s or 60s. So what should you look for? And you might get it too. Well, okay, that's one nutcracker maybe, but usually that's actually younger age. But sure, nutcracker is one. Yeah, that's a good point. What else? Yeah, very good. Renal cell carcinoma, right? Because they thrombose, and then now you have your outflow for the gonadal vein. So think about that also. When you have older gentlemen or middle-aged gentlemen with varicocele, then usually it's something else. Maybe it's a cancer. May Thurner, we talked about yesterday. So what's the original description of May Thurner? Yeah, so left leg DVT. So that's why, which one? So that because of this, well, maybe I should have answered that question first. But left leg DVT is more common than right leg DVT, and that's because of May Thurner. I mean, half of us here might have it, so, but that doesn't mean you're gonna have DVT. But if you go over, you have your lap chole, lap epi, or lap something, you fly, travel long distance, then you might get DVT. So, so it's more common in females, 20 to 40, based on autopsy study. But usually you're right. So because you know you have your cava, okay, and you have your aorta here, right? But this is the bifurcation, right? So the original description was right common iliac artery on the left common iliac vein, and behind it is, so you have a pulsatile structure on top, and what's underneath the vein? The bony structure, right? You're in the pelvis. You have a bony structure, and you have so it's you know, it's a real problem, you know, for these patients. But by the way, it could happen. This is the original description, but you could have external and external. Sometimes you have tortuous patients, you know, aneurysms, whatever. So it could happen external, common on external. I mean, any spots. So it's not just that. Okay, the compression. So we do a lot of dynamic MRs. So also the nutcracker patient that I saw, median arcular ligaments, all these like compression symptoms. So we actually do a dynamic MR, and it really gives you like real time what's happening, and you can see the compression actually that, you know, real time, and that kind of makes you more comfortable that the patient, we have the diagnosis, and Let me see here. Actually, I can't really tell here. Oh yeah, here. There you go. So yeah, I wasn't sure what I was looking at. So this is actually the vein before they join and form the inferior vena cava. And you can see this time it's actually the right again. Like talk about the right is actually compressing. And see how significant it is, right? You have also dilatation, and you have a bony structure. So this is the nice thing about having those dynamic imaging. Looks like nutcracker. There you go. Looks like well, maybe. Is that a nutcracker? Is what you're showing here?
I don't know what it was, but it was
yeah.
just showing these
Yeah.
are dynamic MR scans that we use a lot of to look at flow patterns. And see the flow coming into the inferior vena cava and the pulsatility of the aorta.
But I think that's what it is. You can look at the left renal vein coming across, right? That's SMA, that's SMV here, and that's your aorta. You can see the compression. So it gives you like real time imaging. Again, left renal vein compression. We kind of briefly talked about it. We talked about the perforators a little bit yesterday. So right now we don't really use the cocker, right? We say it's 5 centimeters from the medial malleolus or 10 centimeters. We stop using cocker 1 to 3. I mean that's typically not what you see on the report. And then we talked yesterday about the short saphenous, right, running between the gastrocs or the lesser saphenous and joining the popliteal, and you have the saphenopopliteal junction, same thing like you have the saphenofemoral junction, and then also there's a vein that communicates it to the greater saphenous, the vein of Giacomi, something like that, if I'm pronouncing it correctly. Giacomi, yeah. But you have perforators, voids, and dots all the way up to the thigh. Yeah, I guess what is that? What's that? Typical appearance of valve.
Can you go back one? So one of the reasons, I think I shot this when I was at Emory, and one of the reasons we'd sometimes do this is that if you had a patient who had severe chronic venous insufficiency and ulcers, this is an area you can cut this out, you can expose this, you find that valve, you cut it out, and you transpose that valve down into the leg, and there's enough latitude here you can put the thing back together again.
Yeah. So transposition basically.
It's not done very often.
Yeah. Yes.
This was actually a BKA that we were doing that we just dissected to show what these perforators actually look like. And at that time, one of the procedures that was being done is kind of largely abandoned actually, because now you can see these things with ultrasound. You can stick a needle in them and you can block them off percutaneously. We used to make a little hole in here and put a scope and go underneath the fascia and inflate this area, and you can see these perforators. You come down there and clip and cut them. Problem is there's not a lot of space. It's really, the fascia is not very easily distendable, so there's not a lot of working room when you got instruments in there.
It's called SEPS, subfascial endoscopic perforator surgery or something. Yeah. So I actually did 1 or 2 at DeBakey when I was at DeBakey before we got our machines to do perforator ablations and stuff like that. So again, one of those things that you open a book and you read about it and try to do it. You've never done it before. So again, I guess this is you can see a filter, with a vein occlusion. Now remember, a lot of times you don't know right or left because sometimes some people do these procedures prone, which means patient facing down, so things might get flipped. So just keep that in mind.
But that's the iliac artery impingement. It's got structured.
Oh yes.
It's dilated and flat.
That's typically we use a wall stent to treat May-Thurner. Looks like some anomaly, but I can't figure it out. Is that your hepatic vein?
So yeah, I'm not. That's the hepatic vein. This is the heart. This is the hepatic vein. This is the suprarenal cava. What happened here? Is this stenosis? Do we need to put a stent in the inferior vena cava? Why is it narrowed? Or is it narrowed? Renal's coming in. This is washout from the renal veins, okay? See how nicely opacified it is here? You got this non-opacified blood coming out of both renal veins, washing out. And so this is just a flow artifact. The cave is normal. That's the sort of thing that you will see. And That's about it. I mean, typically this is kind of where you want to position the catheter if you're going to put in a vena cable filter. So 20 for 20, same as in the aorta. Dial the pressure down, 400. You get a nice picture of this. The reason this ruler is in here, this is obviously an old one, is you want to measure the diameter of the cable. Make sure that it's within the IFUs for the filter.
As it gets famed. Oh,
Yeah. Don't see that video.
yeah.
See when the cable's occluded and there's collaterals coming up and chucking the blood from the belly up through the mediastinum up into the chest.
So again, you know, whenever you see, I don't know if you can see in some of these patients with varicosities. So just tell you an interesting story. I had a patient a couple of weeks ago, actually probably now a few months now, came and has huge varicosities coming up and down his chest. No DVT in his legs. He had 3 studies: MRV, ultrasound, no DVT in his legs. And now he came to me and he's like, look, you need to figure this out. I have these chests and everyone keeps saying I have DVT, but ultrasounds are negative. So I see a scar up here. I was like, what's going on here? And he had the pacemaker. So could these, I mean, is it just IVC occlusion that could cause these varicosities, or could you see with also superior vena cava occlusion? It could, right? I mean, it goes both ways, right? So, you know, so I told the guys, like, the problem up here, not down here. And he's like, there's no way. I mean, there's no way you just gave me the problem, solve it in like 1 minute. And sure enough, we did venograms, because he insisted on having venograms. He's a physician. He's actually a general surgeon from Iraq. And sure enough, he had superior vena cava occlusion. That's why he had these big veins. So don't just focus down here. It could be both ways, right? It's collateral pathway. So, so you could have it in both SVC or IVC occlusion. So looking at the, is this,
Not exactly sure how you go to, oh yes, it's the drainage pathway.
Yeah.
Okay, so what's that? Superior sagittal sinus. What's that? Straight sinus. Straight sinus drains into which transverse sinus? Usually the left. I was always told straight left. That's how you remember it. Superior sagittal sinus usually goes right. Sometimes there's a confluence of the sinuses. Basically, oh, here, what's that? 2 of them superimposed. Sigmoid sinuses. And they drain into this bad boy. Okay? Jugular vein. So everything's coming out. You occlude this. This is where the problem actually arises. One time, basically, our neurosurgeon wanted to use the hybrid room because there was severe sagittal sinus thrombosis they couldn't really get access to peripherally. Bored a hole in the guy's head, put a catheter straight into severe sagittal sinus and analyzed that. So there's a bunch of different ways you can get to some of these structures. So generally, when you're doing carotid angiogram, you're supposed to actually follow it through into the sinus phase and the venous phase for the completion of the study.
what's her name, right? Hillary Clinton had some, was it governor's sinus, or she had something, she had some intracranial something.
Really?
Yeah. that explains a lot. No political discussion here. No, I thought you were, you know what, I thought this picture, in addition to the drainage, what was it, what's that thing that you, is it multiple sclerosis that you sometimes balloon the,
Yes.
Yeah, that's largely being
Yes.
described.
Yeah.
Don't do that.
Don't do that.
There was a phase about 2 years ago where there was interest in jugular being internal jugular stenosis as the cause of intracranial venous hypertension. And there's a whole people kind of hog wild put stents in the jugular vein. Now, one of the problems with stent in veins is the change in capacity. And so what happens is a couple of those things migrated out of the jugular vein, you know, into the heart. And then there was a guy in Costa Rica who has had a whole factory of people. Problems, these people are desperate. And I don't think, is anybody doing it anymore? Is it completely gone?
Well, in Europe, they're still doing it in Slovenia, Croatia. So even from US, people are traveling over to Europe to get that. But the problem is that when they come back to US, they're requesting a follow-up by you.
Yeah.
So, and then you really need to come up with something else, like what's your criteria.
you know, at Southern Neville, Dr. Neville was telling me he actually did one, or either was the first or second one, and multiple sclerosis, and she walked. She came to clinic and she walked. She's like, no, this is worse. And then the next 10, 15 he did, none of them really worked.
And I think anybody goes to Buffalo?
Yeah.
Buffalo. It's like Mecca for CCSVI.
Right.
There is a Croatian guy,
Not neck.
somebody know,
Not next place.
neurologist.
Yeah.
But what was interesting is that Meta wanted to do a randomized
Oh, yeah,
study.
that's right.
That was in
Albany, yeah.
and that was also closed down because again they just.
So I'm gonna hand it back to them. They're ready.
Okay, sure. Good. Thank you.
Can I do my interview?
Yeah.
Or you want you have more?
Well, I have no idea. There's way more than we can ever get through, so that's the issue. So,
So from the right, first row, can you pass those two papers you have in front of you? Everybody else has it just. While we are reconnecting, I just wanna.
oh, that's the very end.
Oh, awesome.
Perfect timing. All right, let's finish off with us. Go through this thing. And so, again, we tend to show you normal. Life becomes a lot more complex when it's abnormal. What's going on here? What am I at? Georgetown Medicine. Yeah.
So it looks like you can see the clavicles. So I would say that it looks in there. So I would say that looks like the left
Subclavian artery, vein. Oh, vein. Hard to know why I know that, but I mean it's huge. First of all, it would be an aneurysmal artery. Second thing is if we showed you it would be flowing in that kind of direction, we just can tell that because of the collateral pathway. You just don't get arterial collaterals that look anything like that. So what's wrong with it? Dye comes up, goes all the way around here, and drains back down in the heart. It's occluded. It's an occluded left innominate vein. Why? Pardon? The most common reason we see is because somebody's put a big gas catheter in there. They either got dialysis access, basically defibrillator, pacemaker, or something like that basically is in there. Or it could be thoracic outlet syndrome. Thoracic outlet syndrome usually clots a little bit further out than this, but there are a whole bunch of reasons why this might happen. All right. Opened. Once they open.